Yeah, so we really have not great data looking at patients who get upfront immunotherapy and then in a delayed fashion get a cytoreductive nephrectomy. And then the real question comes, what happens after that? And how do we dictate who we continue treatment on, who we provide a period of active surveillance off treatment, and then who are those high-risk recurrence patients after surgery? I think, the hypothesis from the study is really looking at what happens to that primary tumor on immunotherapy, and does that matter? Can we see some changes in that tumor that help us understand the disease in that particular patient and how they're going to do moving forward after surgery? And so if we see death in the tumor from the treatment that they've been on, there may be some indication there that is present everywhere in all disease in their body, and that they would therefore have a greater progression-free survival after surgery of taking that out. Yeah, so interestingly, what we saw is in this patient population who get immunotherapy and then in a delayed fashion get cytoreductive nephrectomy, the timing of that cytoreductive nephrectomy was pretty consistent. It was around 8 to 12 months, which if you look at the trial data, looking at the Kaplan-Meier curves, is really the time frame where we feel like we can strike while the iron's hot. We're seeing people with durable responses, and we hope that giving them surgery adds to that benefit and then even gives them a period off of treatment. What we found is that if there was extensive necrosis in that tumor that we resected, and that definition would be greater than 95% tumor necrosis in the mass, that those patients had better progression-free survival after their surgery. Now, interestingly, it was not statistically significant if you time that progression-free survival from the start of immunotherapy to their time of progression. And that's probably due to the fact that we're selecting those patients who have a long period on immunotherapy and then pull the trigger for surgery. But once we do surgery, if we see necrosis, extensive necrosis in that mass that we've resected, that did portend to a greater progression-free survival, meaning that they received a better benefit from their immunotherapy up front, and maybe even additional benefit from the surgery itself. Anybody who's done a cytoreductive nephrectomy on a patient that's been on immunotherapy knows that you're going to have one patient who you treat disease-free and you can watch and they do well for a long time before you ever need to reinitiate treatment when they progress. But then there are the other patients that you feel really good about the surgery, you've cleaned them out, and then 3 months later they have diffuse bone metastases, rapid progression. And so if we can identify who those patients are and answer the question of, can we safely, in this patient who we've just done surgery on, stop treatment and give them the relief of not having toxicity from that treatment, increase quality of life after surgery. If we can identify who those patients are and avoid those patients who have that rapid progression, that's a big deal. And we don't really know what to do after these surgeries because we don't have great prognostic indicators of who those patients are going to be. So looking at the tumor necrosis may help guide us in, one, do we continue treatment, do we not continue treatment, and two, how closely do we need to follow them, which is a big deal for patients who are on lifelong treatment for their metastatic disease. There's a time toxicity to these treatments of having to come back for the treatments, but also for their surveillance imaging. And that's days of their life that are lost engaging the healthcare system. So I think it can make a big impact on patients' quality of life and duration of life based on the treatments we choose after surgery. Right now, these data are in a small number of patients, single center, so I don't think anything can be said that this is practice changing or should guide treatment at this time. What we need is more data. We need larger data sets, multi-center data. We need to validate what we've seen here and see that this really is something that we can rely on as a predicting factor in these patients. So just more data looking at this patient population. I think we have relatively limited registry kind of data in patients who get systemic therapy and then receive surgery after that. So it'd be nice to get into the nitty-gritty of also who those patients are who have progression with extensive necrosis and those who don't. And what is it about those patients that despite seeing a treatment response in the primary tumor, didn't have the same benefit that somebody else may with that necrosis. So there's a lot yet to learn about this, but I think it's a promising signal that maybe looking at treatment response in that tumor that we resect might have an impact on patients' lives.